Welcome guys to this topic in which we'll be going to discuss about the stepwise approach to the treatment of elevated intracranial pressure. It will be completely based on the Harrison 21st edition. Now, what is the first thing we need to know before managing a patient who is raised ICP? So, how can we guess whether it is raised ICP or not? One will be there is symptom of severe headache. They can complain of a worst over headache. There will be complaint of like syncope episodes and headache that is not controlled by any kind of medication. Along with, when we check the fundus, you will find papilledema. These are the initial clinical features that will prompt you to suspect that that case can be a headache. You go for a test, you go for NCCT brain or MRI brain that will give features of raised ICP. After that, to quantify how much it was raised, you need to place a ICP monitor. Now, this ICP monitor can be placed by ventriculostomy or via this parenchyma device. Different ways of putting this ICP monitor can be this ventriculostomy, intraparenchymal fiber optic catheter, epidural transducer, subdural catheter, or subdural. Mainly, ventriculostomy is considered as gold standard of it, right? And most visible one remains to be parenchymal device. Right? Now, once you know what is my ICP, once you quantify what is the ICP, you should be very much sure before management what goal you need to achieve. Look, you need to maintain a cerebral perfusion pressure more than or equal to 60 millimeter of mercury for proper functioning of the brain. Now, what is cerebral perfusion pressure? It is nothing but mean arterial pressure minus intracranial pressure. So, you have already checked intracranial pressure by ventriculostomy. You need to check the MEP by systolic pressure and diastolic blood pressure measurement. Now, your primary goal is to maintain cerebral perfusion above 60. Second goal is to maintain ICP less than 20 millimeter of mercury. And you need to maintain intracranial pressure like 20 to 25 millimeter of mercury. You can keep that for around 5 to 10 minutes, like that you need to keep. Okay. Now, how to do that? Non-pharmacologically, we can first try with making proper positioning of the patient. What is the positioning that is accepted? Head end should be elevated, right? Head end should be elevated and head should be in the midline of the head. So, what are the positioning? Elevated head end and head should be in the midline positioning. Next thing that we can try is, once we have put the ventriculostomy for measurement of HCP, by the same technique we can also collect the CSF, right? So we can drain CSF by ventriculostomy if we have already put the ventriculostomy thing to measure the IC. Now, osmotherapy, better than calling that pharmacotherapy, we can call this osmotherapy by mannitol. What is the dosing? Dosing can be 25 gram to 100 gram and it will be every 4th hour, right? Every 4th hour this mannitol using osmotherapy. Now, one thing that should be noted that serum osmolarity, mannitol is osmotic, right? Strong osmotic. So, serum osmolarity should be always maintained less than 320 milliosmol once you start mannitol. Same thing, this osmotherapy can be achieved by hypertonic saline, that is 30 ml, 23.4% NaCl, but mannitol is preferable. Now, if the raised ICP causes due to any brain tumor or brain abscess, which causes nothing but vasogenic edema, you can choose this glucocorticoid activity of the dexamethasone to reduce this vasogenic edema, right? So what will be the dosing? Dosing will be 4 milligram every 6 hours. 4 milligram and this is only. Important thing to note is that glucocorticoid therapy should be avoided in case of head trauma, ischemia, or hemorrhagic stroke. Right? So when we are avoiding this, we are avoiding this in case of trauma, in case of ischemia, and in case of hemorrhagic stroke. Right? Okay. In these three cases, we are avoiding dexamethasone. Now, next thing is that we can keep the patient in sedative condition. With what we will sedate? Morphine per se is a sedative, has a sedative action. Along with it, morphine, we can use propofol or the all known sedatives that like midazolam. Now, once we need to sedate the patient, be sure that this is the condition where we need to put the AT tube, as well as we might need to keep the patient in the mechanical ventilation. Like patient condition has been already deteriorated that we are bound to keep the patient in sedative condition. We can also try hyperventilation once we put into mechanical ventilation to keep a PaCO2 in the range of 30 to 35 millimeter of mercury. Right? But this part is a short-term use, and this step can also be skipped. Short-term use, and this can be also skipped. So this is not at all mandatory. Now, next thing is that what was our goal? Let's again remember that one. Our goal was intracranial pressure to be less than 20 millimeter of mercury and cerebral perfusion pressure to be more than 60 millimeter of mercury. So, what do we know this? What is cerebral perfusion pressure? Cerebral perfusion pressure is MAP minus ICP. So, MAP minus ICP we are keeping less than 20, right? ICP we are keeping as less than 20, right? Less than 20 millimeter of mercury. To make this less than 20 millimeter mercury, MAP should be minimum 80 millimeter of mercury, right? MAP should be minimum 80 millimeter mercury such that CPP remains more than 60. So we need to keep the mean arterial pressure at minimum 80. Look, this is the mean arterial pressure. We need to keep it minimum 80. Better should be in the range of 80 to 120. Right? We need to keep this minimum mean arterial pressure. To make this, we need to give pressure therapy. We can give NORAD, that is norepinephrine, dopamine, or phenylephrine based on the condition of the patient's secondary status, how they respond. Right? Then, if doing all those things, patient still does not respond, we can consider this state to be refractory ICP. Now, what to do in such cases? In such cases, we can go for three options we have. We can go for decompressive craniotomy, number 1. Number 2, we can go for something that is called as high-dose phenobarbital. High-dose phenobarbital result into the condition called as pentobarb coma, and this is very much useful to reduce the ICP. And this picture is like a sort of a peak money for you to remember. Who is he? He is Jack and Rose from the famous movie Titanic. And how did the Jack die? Jack died due to hypothermia. So what did the hypothermia cause to him? Hypothermia caused to reduced ICP too much. That's why Jack died. So hypothermia can reduce Jack's ICP. So hypothermia can be a management protocol for refractory ICP, right? Raised intracranial pressure. So what are the goal for hypothermia temperature? Goal for hypothermia temperature is 33 degrees centigrade. Let's again revise all those things together. So what we did for elevated ICP, how did we sense elevated ICP? We sensed elevated ICP in the form of papilloedema or in the form of headache, severe headache, and we checked through fundoscopy, we found papilloedema. Then we need to monitor the raised ICP. We used a ventriculostomy or a parenchymal device. Then we have decided our goals. Our goal was to make ICP less than 20 and cerebral perfusion pressure more than 60. What we did for that thing, we elevated the head end of the bed as well as made the patient in the Maitland position. if you have put the ventriculostomy tube, we try to drain CSF by this tube only. We tried giving mannitol or hypertonic saline. Mannitol was preferred. We tried giving dexamethasone if the cause was vasogenic edema from tumor. But dexamethasone should be avoided in case of head trauma, ischemia, and hemorrhagic stroke. Right. Now, we can keep the patient sedated. Also, patient will require ET intubation and mechanical ventilation at this point. We can try keeping the patient in hyperventilation condition with PaSO2 between 30 to 35. We can try pressure therapy to maintain mean arterial pressure at least 80, right? And if after at all those the ICP is not managed, we can consider this. We are going to consider this a refractory ICP and try different decompressive craniectomy, high-dose barbiturate therapy, which is also known as pentobarbital, or try to maintain hypothermia. And what is the temperature of hypothermia that needs to maintain? It's 30 to 50%.